next to me. I guess it was lunch. Okay, hi everybody. I already talked about the melon team, so I said we're a diverse group with all different backgrounds because of the melon family, not the fruit melon, but the melon family with an E. Okay, so we are going to start with Christina. Can you tell us something about your role at the Melon Center and a fun fact?
Good evening, everybody. My name is Christina Duncan. I'm an occupational therapist at the Cleveland Clinic Mellon Center. And a fun fact is I'm not originally from Cleveland. I'm from Mississippi.
There you go. Southerner. Oh, okay. The Southerners are taking over. Okay, Allyson. Allyson, you're up.
Okay, my name is Allyson Krueger. I am a social worker at the Cleveland Clinic Mellon Center as well. And a fun fact would be that I play the violin.
Oh, I didn't know. I'm going to have her do concerts now. Okay, Francois, you're up. Just click it up. Yeah. Well, Christina, the OT, will help you.
I'm technologically challenged, I guess. I'm Francois Bethoux. I'm the only one who didn't get the memo about the pink color. So I got the wristband, though.
There you go. Good work.
Sorry about that. I'm a rehab physician, and I've been at the Mellon Center for almost 27 years. Let's not date ourselves there. And so I've been taking care of the patients there, mostly for spasticity issues. And fun fact, actually kind of related to yours, is that one day I ran after a famous violinist in an airport so that my daughter could take a picture with him.
Cute.
And the guy was not amused at all.
Yeah, because she was a violinist. She is.
What's that?
Was your
Yeah.
daughter a violinist?
Yeah,
Or is,
yeah, it's it.
He's very artsy. His family's very artsy. Okay, Desiree, you're up.
Hopefully.
Hopefully, you're on.
Okay,
Yeah,
okay, good. So my name's Desiree Chizmadia. I'm a nurse practitioner at Mellon Center, and of course I work with Dr. Rensel.
Oh, yes, she does. We're a
We're
team.
We're a team. A fun fact about me, which I don't know if it's really a fun fact, but it is a fact. I am a Disney nerd freak. I've probably been to Disney World over at least 20 times.
100%.
Yes.
100%. This one.
So if you guys need Disney tips and tricks,
Yes.
I'm your girl.
She's your Disney connection. That's so true. Oh my gosh. Okay, Christina, we're going to start with you again. Can an OT, which is an occupational therapist, help with fatigue? Grace. I forgot Grace. I did not forget Grace. Ironically, Grace is behavioral medicine. Now we're going to have to talk about feelings.
And you hurt mine.
Sorry. I hurt your feeling. I'm so sorry. I feel sad that I missed you. Go ahead, Grace. Tell us about
We
you.
have redemption now. Hi, everyone. I'm Grace Tworek. I am a clinical health psychologist at the Mellon Center. A fun fact, I'm Canadian, so if we have any hockey fans, go Oilers. Even though we're not doing that good right now.
Hockey fans?
We can
Okay,
still make a comeback.
Nice. I do apologize. Okay, back to OT. Can an occupational therapist help somebody with fatigue?
Yes.
Yes. How would they do that?
So we would talk to you about like how tired you usually are, what things make you tired, and just kind of get an overall assessment of like how your day is going, and then give you strategies to be able to manage that fatigue, whether that's like organization of your day, work with the doctor if there's any medication that you could be on that's going to help manage that fatigue, and then just work with you on energy conservation techniques.
Love it. Thank you very much. Desiree, when do we want to hear from our people who are living with NMOSD or MOGAD as far as their symptoms go? When should they contact their healthcare team?
So anytime, I don't know, sorry. Anytime there is a new symptom, so anything new, anything worsening more than 24 hours, because we definitely know symptoms will fluctuate day to day, but anything new, anything lasting longer than 24 hours is when we want to hear from them for sure.
Okay. How should they contact us?
Anything urgent, we would definitely want a phone call. If it's something that could wait, message us through my chart. So.
Okay. Very good. Thank you. Allyson, how can a social worker support somebody living with NMOSD or MOGAD?
So I think there's a lot of different resources that social workers can help with. So as far as transportation to appointments, that's a big one that I help with. Another one is completing advanced directives, such as a healthcare power of attorney, a healthcare living will. What else do I do?
You do so much. She does some. What about ramps? You help connect with
So any
foundations.
specialized equipment. So if you're needing ramps, if the OT or PT recognizes that you need some sort of specialized equipment, that's something that we can usually help out with. The National MS Society is a good organization that typically helps out financially. And then also future planning. So we do a lot of future planning with patients and families to kind of prepare like what that's going to look like for the future.
Love that. Also, yeah, and family meetings. So a lot of times the patient maybe has an idea of how things are day to day, and the family will call us and be like, don't tell the patient that I'm calling because I'm concerned they're falling a lot or something. And we say, we have to tell the patient that you care. So sometimes we bring everybody in the same room, or Allyson will facilitate a meeting, so we can all just get it on the table. What are we all concerned about? How are the days going? Where can we support or connect with resources? So we get a lot of those calls, like, please don't tell him I called you. Like, well, why wouldn't we tell him that you care and that you are concerned? So that's something that a lot of times Allyson helps to facilitate a nice conversation where we can just get it out on the table. What is the reality and what can we connect people to? I love that when you help us with that. Okay, Grace. I still feel bad. Okay. So Grace is a behavioral medicine specialist. Can you raise your hand if you know what that means? Yeah, see, it's a term I don't think a lot of people use. So could you explain who should see you? What kind of patients come your way? What can you help them with? Please.
Absolutely. So in behavioral medicine, what we are really doing is identifying different areas of your life where you may be experiencing an exacerbation of symptoms or experiencing mood symptoms. So maybe anxiety, low mood, and things like that. And we come up with different behavioral interventions that may help to manage those symptoms. So we are made up of a team of health psychologists, and our bread and butter, as we like to say, is often stress management. You've heard today that different areas of your life that contribute stress can exacerbate the way we experience symptoms. So if we can build a strong set of stress management skills, that can really help us to manage those symptoms. So we work alongside your team to build a really strong tool belt of different coping skills, and we also provide support groups as well. So that's a big thing that we do, is connecting patients to one another and caregivers to one another as well, so that they can understand that they're not alone, feel validated in some of the symptoms or experiences that they're having, and have connections and different resources.
That's wonderful. Thank you for explaining that. Can you tell us about some of your groups? I know you have groups with different topics or focus. Can you share a few of those?
Absolutely. Please. So currently, we have a caregiver support group that meets once a month. We have an autoimmune encephalitis group that meets once a month, and a few different support groups for our MS folks, but we are looking to expand those groups to include NMO and MOGAD as well. So that's something that's, on the docket there. And we kind of like to try to break down our support groups to find like-minded folks. So what I mean is, in our MS population, we have what we call a young professionals group. So those are folks mid-20s to mid-40s, raising families and career, actively on DMTs. And then we also have a men's support group. We find that our men tend to open up when they are with other men. So we really try to identify needs and create those groups as we can to connect patients.
Wonderful. Thank you. Dr. Bethoux, can you explain to us, please, the difference between a rehabilitation doc and a neurologist, and what tools you use to help folks?
How many hours do we have?
We have a lot. We have the whole day. I'm sure Samara will not mind if we just go on and on.
Actually, I don't emphasize the difference as much as the fact that we work hand in hand. But my experience at the Mellon Center, which has been wonderful with all the neurologists there, is that sometimes the symptoms get so severe, so complex. These are complex diseases, NMOSD and MOGAD, right? Life is complex. And sometimes there's other ailments that develop. Maybe I don't, my legs don't really walk straight. So then my back will start complaining. My hip will start complaining. And all of this seems to conspire to make it difficult to function, to enjoy daily activities, right? To have fun with the kids, to finish the day at work and not, just be unable to do anything else. So it's when things become complex like that, and when, functioning becomes very difficult, then we can try to detangle these complex situations and honestly, work with other services and everybody present here we've been working with to try and address these so that function can become better. Particularly, we also address the issue of spasticity, which is not that uncommon with NMOSD and MOGAD. And, stiff and spasmy muscles that sometimes can be painful, sometimes can wake people up during the night. And again, sometimes with simple medications, good stretching, physical therapy, that can be taken care of. But then when it's kind of more resistant to these treatments, then we can apply others like, botulinum toxinations like Botox. I use all the leftovers. That's why I'm really 99, but I look pretty good. Or baclofen pumps. The point is, that's where we really like to help. We do not replace anyone, but we like to be part of the team so that we put a dynamic spin on things. We don't like to give in to the disease or give up on the disease, but use all the tools we have to make it so we optimize our quality of life and ability to function.
Thank you very much. Okay, ladies and gentlemen, you have in front of you a rehab doc, a behavioral medicine specialist, occupational therapist, social worker, and advanced practice provider. Any questions? You can ask them some questions. If you raise your hand, we can bring some questions forward. Anyone? If not, we'll keep going. Yes, Dr. Kunchok.
I was just thinking about Christina and visual impairment and what sort of things, like it's quite unique for NMOSD and MOGAD that vision is quite impaired probably compared to MS. And I just wonder what sort of things from an OT perspective you can do.
So the question was visual impairment and these disease states. What can occupational therapy help with any kind of visual impairment?
Well, specifically, I just got my low vision certification, so thank you. So we can help with, we're not gonna, let's say, fix your vision, but the things that you are having concerns about or problems with, we can help to navigate that and find ways for you to be able to be independent and do the things that you need to do. I have a patient here today that I see for vision, and we work on a lot of visual field training and scanning so that you're not running into things, you're able to do your job well if you're still working, and able to take care of your family and do the things that you need to do. So we are more focused on the function with the vision that you have.
Okay, thank you. That's exciting. I didn't know you had. That's neat. Okay, any other questions? So I'm going to keep going if you're quiet. I know you're not shy. Yes, in the back. Dun, 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 dun. Watch Jill run. Go, Jill, go. Oh, shoot.
Got it.
Oh, there you go. Got it.
My question for all of y'all or whoever is, how do you help guide patients with their comorbidities or other, factors that they might be living with that could make their NMO-MOG worse, or vice versa?
Okay, maybe Desiree, is this you?
No, that's a really good question. So a lot of times that's like a focus of a lot of like the advanced practice providers visits. So when we see patients, a lot of times we are doing symptom management with these patients. So when we see patients and for visits, we want to make sure that we're meeting those day-to-day needs. We want to make sure that you're able to do what you want to do on a day-to-day basis, but we don't want like MOGAD or NMO to kind of be like an inhibiting factor day-to-day. So a biggest focus of our visits are to make sure we're managing and meeting symptoms. And sometimes we know we don't meet all of those in one visit, and it might take multiple visits to get some of those symptoms and manage some of those things to kind of help kind of fix that day-to-day stuff. So does that kind of help answer your question? Okay, not a problem.
Okay, I have a question for Allyson, our social worker. Okay, we'll get you in 1 second so the microphone can get you, and then we'll do this first. Allyson, can you walk us through a process of disability as simply as you can? Because some people ask us, like, I can't work a full day at work.
Okay.
So how, a lot of times we share them with you so that you can walk them through a process.
Yeah, so a lot of times I get patients that are referred to me to talk about the disability process. It's not necessarily meaning that they need to be on disability right away, but just to like kind of talk about like the future. And what that looks like is I kind of look in the notes, make sure that they have a lot of documentation that's needed, like for physical impairments or cognitive impairments, vision changes, things like that. And then we would kind of collaborate with the APPs and go over additional testing if needed. And then from there, after the additional testing is completed, we meet again and talk about how to apply if the additional testing qualifies them for disability.
Okay.
So.
Thank you. Thank you very much. Okay, we can go back to the question in the middle of the room.
I was just wondering, have you found any like dietary or supplements or exercise plans that do help with symptoms or progression of illness?
Sure. Yeah, Desiree's back on. She's busy. Yeah.
So this is a very, very hot topic, and this is actually something we cover a lot of times in visits. So really, it depends on what you kind of bring into the visit. So I know sometimes people like, I saw this on social media, what about this or what about that? There's nothing specific that we recommend in terms of supplementation at this time. There really isn't. But we're not opposed to, if someone brings something to us, looking it up and kind of having that discussion with you like during a visit. It's definitely not something we're opposed to. We just want to make sure that if it's something you want to try, we want to make sure that's nothing impacting other your medications. In terms of diet, we just kind of recommend a Mediterranean diet, something whole balanced, has a lot of fuel for protein, but nothing other like a specific kind of diet that we kind of recommend. Does that kind of answer your question? Yeah, nothing that we're aware of, but just more of a whole balanced Mediterranean diet is what we kind of encourage for our patients.
Love it. Thank you. You want to, talk about movement? Dr. Bethoux's on it.
I love to talk about movement. I just wanted to finish answering your question about exercise. There actually has been a lot of research into exercise in MS, and we know, NMOSD and MOGAD are different, but they share some common characteristics. And I think the overall recommendation is, there should be some form of exercise. It doesn't hurt the disease, right, to be more active and try to exercise. And so the general recommendation is to do some form of aerobic exercise about 3 times a week and some form of resistance training. So resistance training is like weights, bands, about 3 times a week as well, not necessarily on the same day, and for the amount of time that's tolerated. So these are the guidelines, and as always with guidelines, they're great, but then how do they apply to me, right? And that's where I think we rely a lot on our rehab specialists, the physical therapist, occupational therapist, to say, okay, I can't just go to a gym, put on that silly video on YouTube where people are like jumping up and down and do that for 30 minutes. It has to be adjusted to me. I would say where there's a will, there's a way. And it's very important that you keep asking. And sometimes you will find a trainer at a gym that kind of gets it and is willing to communicate with Desiree or Dr. Rensel or one of our therapists to say, okay, this is what may be safe to do, why don't you try that, etc. I will really not give up, because one of the factors that have been shown to cause more trouble, including these comorbidities that we talked about, is lack of activity. And you all know it's not easy, right, to stay active with a disease that makes you tired, causes weakness, causes pain, etc. So that's also what we're here to help with.
Thank you. Grace, I'm wondering if you could walk us through a nondescript patient, don't, of course, no names, but like somebody who has come to you and how it impacted their lives, the services that you offer?
Sure, absolutely. So someone that comes to mind or a situation that comes to mind, I'm lucky in that I have 2 half days where I get to go into our inpatient side of the hospital and meet folks who are hospitalized, chat with them, introduce who I am, what our services are, and bridge them to outpatient care. So oftentimes, of course, when you're in the hospital, it's uncomfortable. There's people coming into the room. You might be receiving a new diagnosis, right? So my goal is to be there, be someone that you can talk to who understands. So you don't have to take on that teacher role and explain all of these things to me. That's why I round with some of our neurology folks. That's why I, attend all of their grand rounds so that I have that information so that I can be there, talk with you, be present with you. And then really from there, the goal is to bridge to outpatient services, whether that be individual services, so like doing individual therapy with me once every month or whatever a timeline that works for you, or our group therapies. But really, what we're trying to do is to get you back to doing the things that you love with the people that you love. That might look different for each and every patient that comes to see me, but that's why it's individual therapy, right? We're trying to find the things that stick out for you or things that you would like to maybe change or feel are more well managed for you. So it really can vary, but our goal is to meet you where you're at, be a place where you can talk about some of these things, and also have a space that's just for you. And we also do virtual visits as well, because we also understand that sometimes coming into the Mellon Center or the clinic for some folks can be a trigger to, when they were diagnosed or to some of the more difficult visits they've had. So if we can find a space too that's really comfortable for you so you feel like you can open up and share, we can do that in office, we can do that virtually.
Love it. Well, yes, Dr. Abbatemarco.
Quick, I was just talking to one of our patients here about Christina and the rest of the OT program with driving. I think Dr. Tworek just mentioned how important driving and transportation. What kind of programs are available, and how do we help patients who driving is a concern?
Yes. So Cleveland Clinic does have a driving rehab program. And what our goal is to always to keep people driving as long as it's safe to do so. So to get into that program, you would need a doctor's order. For occupational therapy. It's a 2-part program where we would do a clinical evaluation just of like your strength, range of motion, your reaction time, those kind of things. And then the second part of the program would be in a car where we would take you would take us out because you would be the one that was driving, and just kind of see what issues you are having and remediate those issues. We will also evaluate if you need adaptations for driving. So let's say that your leg weakness, you are unable to use the gas and brake like you normally were, you'd be able to drive with hand controls. So we do the training for that as well, and get you back to driving.
Thank you very much. Okay, everyone. Well, thank you for your attention, and please help me thank this panel of amazing